Good evening, everyone. Today we are going to discuss a topic that touches the lives of many of our patients, perioperative insulin therapy, or how we manage insulin before, during, and after major surgery. Through this session, I will not only walk you through protocols and guidelines, but also help you see the human side of this subject, because behind every insulin adjustment is a patient waiting for surgery, worried about their future, and trusting us to keep them safe. The aim of today's session is very clear. We want to understand how insulin is best managed around the time of surgery, why poor sugar control is so dangerous, and how new approaches and technologies can help us. We'll also explore the science behind surgery and glucose metabolism so that we understand what the body is going through. By the end, I hope you'll see not just the what of insulin therapy, but also the why and how, with the patient always at the center. Let's pause for a moment and ask, why does this matter so much? Because sugar balance saves lives. When blood glucose climbs too high, the risks multiply, wound healing slows down, infections set in, and the patient's chance of a smooth recovery drops. On the other hand, when sugars drop too low, the consequences are equally dangerous: severe brain injury, confusion, even cardiac arrhythmias. That's why we walk a narrow path, aiming for glucose between 140 and 180 milligrams per deciliter. It's not just a number, it's the difference between complication and recovery. Every surgery is a stress test for the body. The moment a patient is wheeled into the operating theater, stress hormones, cortisol, adrenaline, noradrenaline, and glucagon surge into the bloodstream. These hormones are meant to help survival. They push the liver to make more glucose, they make tissues resistant to insulin, and they break down fat and protein for energy. For someone without diabetes, this is manageable. But for a diabetic patient, this storm of hormones can push sugars dangerously high, creating new risks right on the operating table. High sugar during surgery is not just a lab result, it is a silent saboteur. It draws water out of the body, causing dehydration and electrolyte imbalance. It triggers acid formation, impairs immunity, and floods the body with inflammatory signals. At the microscopic level, it injures mitochondria, weakens blood vessels, and slows down healing tissues. All of this adds up to one outcome: poor recovery after surgery. This is why controlling hyperglycemia is not optional, it is essential. Before we go further, let's remind ourselves what insulin does. It is not just a medicine, it is life support. Insulin drives glucose into muscles and fat where it can be used, while stopping the liver from making unnecessary glucose. In the perioperative setting, this simple hormone becomes our strongest ally. How we use it determines whether our patient comes out of surgery stronger or faces unnecessary struggles. An insulin regimen has 3 important parts, and each one matters. First is basal insulin, which quietly works in the background to keep sugars steady even when we are not eating. Second is prandial or nutritional insulin, which steps in when food enters the body, matching the carbohydrate load. And third is correctional insulin, which acts like a safety net, bringing down sugars if they rise unexpectedly. Together, these 3 create a delicate balance. If even one is missing, the system falters. It is also important to remember that not all diabetes is the same. A patient with type 1 diabetes is completely dependent on insulin, and even a short break in supply can lead to ketoacidosis. Type 2 diabetes, in contrast, involves insulin resistance and requires flexible strategies. Steroid-induced diabetes is increasingly common in transplant and oncology patients, while gestational diabetes presents its own challenges, especially in C-sections. Understanding which category our patient belongs to helps us plan insulin therapy that is safe and tailored. Now here is something that really highlights the scale of the problem. Almost 1 in 3 surgical patients has diabetes. In certain operations like cardiac surgery, the numbers go as high as 90%. This is huge. And with diabetes comes a higher risk of infection, longer hospital stays, and greater chances of being readmitted. It tells us that perioperative insulin therapy is not a side issue. It is right at the heart of safe surgical care. The American Diabetes Association gives us very practical guidance. For most patients, we should aim to keep sugars between 100 and 180 within 4 hours of surgery. For elective surgeries, the HbA1c should ideally be less than 8%, and we must always avoid hypoglycemia. The key message is balance. Trying to push sugars too tightly into the normal range does not improve outcomes, but it does increase the risk of hypoglycemia. So moderate, safe control is best. When sugar control is poor, the consequences are serious. Wound healing slows down, infections become more common, recovery drags, and complications rise. And beyond physical harm, poor control also shakes the patient's confidence, makes families anxious, and increases the overall cost of care. So, glycemic control is not only about clinical outcomes, it is also about dignity, trust, and giving patients the best possible recovery. Managing perioperative insulin is not a one-person job, it is a team effort. The endocrinologist helps design protocols and adjust insulin. The surgeon decides timing and assesses risk. The anesthesiologist monitors glucose during surgery. Nurses carry out the plan at the bedside, and dietitians make sure nutrition supports healing. When each member plays their role, the patient benefits. It truly is teamwork that makes surgery safer. Before surgery, every diabetic patient should have a proper assessment. HbA1c should be checked if it hasn't been done in the last 3 months. Kidney function matters, especially if the patient is on metformin. We also need to review all medications, look at cardiovascular, renal, and liver comorbidities, and ask about past hypoglycemia or ketoacidosis. This checklist ensures that no risk is missed, and every patient is optimized before stepping into the operating room. Sometimes numbers speak louder than words. If a patient's HbA1c is over 9%, we should think carefully about going ahead with elective surgery. The risks of poor wound healing and infections are simply too high. In such cases, it is better to delay surgery, optimize sugars with a basal bolus insulin regimen or continuous glucose monitoring, and provide nutrition counseling. Waiting for control today means safer outcomes tomorrow. Now comes the practical part. How much insulin should we give? For most patients, the total daily dose is about 0.4 to 0.5 units per kilogram per day. If the patient is elderly, frail, or has kidney or liver disease, we give less, around 0.2 to 0.3. If the patient is obese or on steroids, we may need more, up to 0.6 or 0.7. Once we calculate the total, half goes as basal insulin and the rest is divided across meals as nutritional insulin. Monitoring is key. If the patient is eating, check before meals and at bedtime. If they are fasting, check every 4 to 6 hours and use correctional doses as needed. The idea is always the same. Safety first, balance always. When a patient is critically ill, things change dramatically. In the ICU, subcutaneous insulin is no longer reliable because poor circulation and unstable hemodynamics make absorption unpredictable. Here, the safest approach is a continuous intravenous insulin infusion. Regular insulin is preferred because it has a short half-life and can be titrated minute to minute. Blood glucose must be checked every 1 to 2 hours. Transition to subcutaneous insulin is only considered once the patient is stable, off vasopressors, and glucose levels are steady. This approach gives us control in the most unstable situations, preventing dangerous swings. Moving from intravenous insulin back to subcutaneous is a delicate process. We calculate the basal dose using the average infusion rate over the last 6 to 8 hours, then multiply it by 24. About 70 to 80% of this becomes the total daily subcutaneous dose. If the patient is fasting, the entire dose can be basal insulin. If the patient is eating, we split it. Half basal, half nutritional. Most importantly, we always overlap IV and SC insulin by 2 to 3 hours. This overlap prevents a rebound rise in glucose, a mistake that can undo all the hard work of careful ICU management. Now you may wonder, if surgery pushes sugar up, why do we often reduce insulin doses before and after surgery? The reason is balance. Yes, stress hormones increase glucose, but at the same time, fasting reduces carbohydrate intake, anesthesia may temporarily improve sensitivity, and kidney or liver dysfunction can slow insulin clearance, so giving the same dose risks hypoglycemia. This is why insulin adjustment is so important. It protects patients from both extremes. hyperglycemia from stress, and hypoglycemia from reduced intake. The night before surgery, we never stop insulin completely. For long-acting basal insulin such as glargine or detamir, the dose is usually reduced by 20 to 25%. If the patient takes basal insulin only in the morning, we reduce that morning dose. For twice-daily regimens, both evening and morning doses are reduced. In patients on very high doses, or in elderly patients with kidney or liver disease, the reduction may be even greater, up to 50 or 75%. For intermediate insulin like NPH, the evening dose is unchanged, but the morning dose is cut in half. This careful adjustment prevents dangerous lows during fasting, but maintains enough coverage to avoid ketoacidosis. Premixed insulins are trickier. Ideally, patients should be switched to a long-acting insulin the evening before surgery. If that's not possible, the morning dose is reduced by half, and the patient is supported with IV dextrose fluids, or the dose is skipped altogether and replaced with long-acting insulin in the pre-op area. The golden rule is never to stop insulin entirely in a diabetic patient, because hyperglycemia and ketosis are far more dangerous than a controlled mild elevation. Oral agents are usually stopped 24 to 48 hours before surgery, and in major cases or unstable conditions, IV insulin infusion is preferred because it is more reliable than subcutaneous absorption. During surgery, the approach depends on the length and complexity of the operation. In shorter procedures lasting under 4 hours, with stable vital signs and little fluid shift, subcutaneous rapid-acting insulin every 2 hours may be enough, with blood glucose monitored at the same interval. But in longer or complex operations, over 4 hours, with significant fluid shifts or hemodynamic instability, if blood glucose crosses 180 mg per dl, an intravenous insulin infusion is started and sugars are checked every 1 to 2 hours. This proactive management keeps sugar stable and reduces post-operative complications. The story doesn't end when surgery is over. In the recovery room, we review how sugars were controlled during the operation and continue either intravenous or subcutaneous insulin with close monitoring. If the patient is stable and eating, they can often be discharged on their previous regimen. For non-critically ill inpatients, insulin choice depends on whether they are eating or not. If they have poor or no oral intake, we rely on basal plus correctional insulin. If they are tolerating food, we use the full regimen, basal, nutritional, and correctional. In other words, insulin after surgery must be flexible, personalized, and dynamic. One of the most overlooked steps is patient education. Before surgery, we must explain the risks of both high and low sugars and how insulin will be adjusted. Patients should be given written instructions about fasting, medication adjustments, and what symptoms to watch for. Importantly, consent must cover insulin therapy and, where used, continuous glucose monitoring devices. When patients understand the plan, they are calmer, more cooperative, and safer. Continuous glucose monitoring, or CGM, is becoming an important tool, especially for patients with brittle or unstable diabetes. It gives us real-time glucose readings, allowing faster interventions. But CGMs must be calibrated and always backed up with fingerstick checks in the perioperative setting. Used wisely, they can reduce both hyperglycemia and hypoglycemia and add another layer of safety for high-risk patients. To bring it all together, every diabetic surgical patient should go through a structured checklist: HbA1c, kidney function, medication review, comorbidities, and history of sugar extremes. This checklist should be documented in the electronic record and communicated clearly to the surgical team. It acts as a safety net, because in surgery, what we fail to plan often turns into what we regret. When IV insulin is used, it should never be improvised. Validated protocols, such as the Yale or Portland protocols, give us reliable rules for titration based on hourly glucose checks. These protocols reduce guesswork, improve outcomes, and create consistency across different clinicians. The principle is simple: follow evidence, not intuition. Our target is not perfection, it is safety. Glucose levels below 70 or above 250 mg per dl must be avoided. Within that, the range of 100 to 180 is ideal for most patients. but adjustments can be made depending on age, comorbidities, and overall surgical risk. The message is clear: individualize, but avoid extremes. No surgical team should ever be unprepared for hypoglycemia. Dextrose and glucagon must always be available in the operating room. Every episode of hypoglycemia must be documented and reported because one missed low can be life-threatening. The operating theater is a high-stakes environment, and readiness makes the difference between a crisis and a smooth recovery. On the other side, hyperglycemia must also be managed carefully. Random insulin boluses should be avoided unless part of a clear protocol. We must also keep a close eye on potassium and hydration because insulin can shift electrolytes and fluids. Treating high sugar is not just about lowering the number, it is about maintaining stability and preventing further complications. Among all the team members, the anesthesiologist is often the unsung hero of glycemic control. They monitor glucose intraoperatively, adjust fluids and insulin rates, manage emergencies like sudden hypoglycemia, and document every intervention. They also coordinate with the endocrine team to ensure continuity. In many ways, the anesthesiologist acts as the guardian of metabolic stability during surgery. For patients with type 1 diabetes, one rule stands above all: never stop insulin completely. Even if they are fasting, even if their sugars seem normal, insulin must continue at a reduced dose. Without it, the body quickly shifts into ketone production, and diabetic ketoacidosis can develop within hours. This makes them one of the most vulnerable groups in surgery. Extra vigilance with ketone monitoring and anion gap checks is essential whenever their glucose begins to rise. Patients with type 2 diabetes have different challenges. Many are on oral medications such as metformin, which must be stopped 48 hours before surgery due to the risk of lactic acidosis in case of renal compromise. Others may respond slowly to insulin adjustments due to underlying resistance. For them, close monitoring and timely dose titration are critical. While the urgency of DKA is less compared to type 1, the danger of infection, poor wound healing, and prolonged recovery is very real. After surgery, blood sugars don't always behave predictably. Anesthesia itself can mask hypoglycemia, and stress hormones may keep glucose high for days. That's why frequent monitoring is key, not just reacting to single numbers but watching for patterns. Glucose checks should guide gradual adjustments, preventing sudden swings. It's a reminder that surgery recovery is a marathon, not a sprint. One of the most powerful arguments for strict sugar control is infection risk. High glucose suppresses the immune system, fuels bacteria, and makes surgical site infections more likely. Keeping sugars under 180 mg/dL significantly reduces this risk. For patients already at high risk, such as those with prosthetic implants or long surgeries, this can mean the difference between healing well and months of complications. Sometimes antibiotic prophylaxis is also considered, but nothing replaces the value of stable sugars. Steroids are often used after surgery, particularly in transplant or neurosurgical cases. But steroids come with a hidden cost. They raise insulin resistance and cause glucose to spike hours after administration. This means we must anticipate the rise and check sugars 4 to 6 hours after every steroid dose. If we wait until the spike is already severe, the patient suffers. Anticipation is the real key here. Surgery doesn't end when the patient leaves the hospital. Discharge planning is critical. Patients and families must receive written instructions, clear guidance on insulin dosing, and an emergency contact number. They should know the warning signs of hypo and hyperglycemia and when to seek help. Without this, many patients end up back in the emergency room within days. Empowering them with knowledge and confidence ensures continuity of care at home. In today's world, telemedicine is a powerful ally. Virtual follow-up after surgery helps patients share glucose logs, adjust doses, and get reassurance without frequent hospital visits. Remote monitoring reduces readmission rates and prevents small problems from becoming crises. For patients in rural areas or with limited mobility, this can be life-saving. It's a reminder that technology, when used well, extends the safety net beyond the hospital walls. As we near the end, let's summarize. Safe perioperative care comes from using standardized insulin protocols that are tailored to each patient type. These must be clearly documented and communicated across the team. Whether it's adjusting basal doses, switching to IV insulin, or planning discharge, consistency is what prevents errors. When everyone follows the same playbook, outcomes improve. So, what are the key messages? First, glycemic control is critical for surgical safety. Second, we must use evidence-based insulin protocols before, during, and after surgery. Third, teamwork across specialties ensures that no aspect is missed. Fourth, patient education and early discharge planning make a huge difference. And finally, monitoring and adjusting are not optional. They are the heart of safe practice. Or, as I like to put it, balanced sugars, smooth surgery, safe recovery. Let's test ourselves with a case. A 65-year-old woman with type 2 diabetes is scheduled for elective hysterectomy. She takes Glargine 20 units in the morning and Lispro 6 units with meals. Her HbA1c is 6.8% with no hypoglycemia episodes. What should we recommend on the day of surgery? Option A, no change. Option B, hold Lispro and take 16 units of Glargine. Option C, hold Lispro and reduce Glargine the day before and day of surgery. Option D, hold Glargine and take Lispro instead. The correct answer is B. Nutritional insulin is withheld to prevent fasting hypoglycemia, but basal insulin must continue at 75 to 80% of the dose, so she should take 16 units of Glargine. Here's another case. A 70-year-old man with type 2 diabetes on Detamir, 40 units twice daily, and glulicine 10 units 3 times daily is admitted with septic shock due to gangrene. He is hypotensive on norepinephrine, febrile, and scheduled for emergency amputation. His glucose is 350. What is the best management? Option A, continue basal insulin at home dose. Option B, reduce basal by 20 to 25%. Option C, start IV insulin infusion. Option D, reduce both basal and nutritional by 20 to 25%. The correct answer is C. In critically ill patients with poor perfusion, subcutaneous insulin is unreliable. Intravenous insulin infusion is the safest and most effective approach. And with that, we come to the end of our session. We've seen how perioperative insulin therapy is not just about numbers. It's about protecting patients during one of the most vulnerable times of their lives. By balancing sugars, anticipating risks, and working together as a team, we give our patients the best chance for a safe surgery and smooth recovery. Thank you for your attention.